Thanks for joining us today. I see we have a great turnout. So, if you don't know, my name is Matthew Greco. I'm the Advanced Manager here at PSS Life University. And this morning we're having a great topic for everyone, whether they're an older adult or not, on memory and aging. You all saw the introduction to sign up. And today we have Dr. Sonica Bhatia and Eileen Callahan.
I'm Sonica Bhatia, and thanks again for inviting both of us to come in. And thank you to all of you for logging on to hear what we have to say. So we are going to talk about memory and aging and what's normal and what's not, because I imagine many of you might be thinking about this all the time for yourselves or for your loved ones. I know it's something I think about these days myself, even for myself. So here are some questions that we hope by the end of this discussion, you'll be better able to answer, when you talk to your partner or your friends about what you attended this afternoon. So these are some questions that we hope you can answer after we go through our talk. What are normal changes with memory as we age? What is the difference between mild cognitive impairment and dementia? That's something you may see when you're reading about memory changes with aging, or you might see if you go onto your patient portal and you read the notes about yourself or your loved one, you might see those terms. So we want to make you more empowered to better understand what the doctors are actually talking about when they write that. How does a doctor actually evaluate for dementia? And are there medicines to treat dementia? And then I think importantly for all of us, regardless of our age, is how can we keep our brains healthy? So with that, we'll keep on going and answer these questions. So here I have a slide show that you're going to see a few times during this talk to think about the spectrum of cognition. So there's normal aging, and then there's in the middle we have a term called mild cognitive impairment and dementia. And we'll go through each of these and describe them. Okay, so starting with normal aging, we'll describe what the changes in memory and cognition are that you can see with normal aging. And how many of you have this, have had an experience like this where you kind of are trying to work some new technology and it's challenging and you wonder, what does that mean? So you see here this young lady trying to send a text with her rotary phone. And with the new technology, I think it often is a challenge. I know myself, I'm trying to remember all my 9 million passwords. And if I have to do a double verification, it's often challenging. So this often makes a lot of people question their memory and their cognition. So let's talk about what normal aging really is. So it is a mild slowing of memory, especially with the retrieval of a word or a name, kind of the tip of the tongue syndrome, we call it. You're trying to think of that actor from a movie that you saw decades ago, and it's right there, but you can't quite get it out. That's kind of some of the slowing that we see with normal aging. Maybe you're misplacing some items occasionally, so especially things that you use frequently, like your cell phone or your keys. Maybe you're struggling to find a word, but then it comes back to you later. Of course, too late, but it does come back to you. Maybe you might forget the name of an acquaintance and you're trying to jog your memory on that one. Challenges with new technology we talked about. What makes this still normal aging, all of the things that we just talked about, is that you're still independent in your daily life. So there's no changes. So if normally you are a great chef, please invite me over for dinner, but also, you'll continue to be a great chef. You'll continue to still be making these complex meals. And if you are somebody who's always kind of kept track of your medications really well or your doctor's appointments, you're still able to do that. And on testing that would be done in a doctor's office, your testing actually comes out normal. So those are the things that we look for when we're thinking about normal aging. I think the real key, and you'll see this as we go on and describe those other terms, is in terms of those terms of mild cognitive impairment and dementia, is that you're independent in your daily life and there's normal memory testing. So here you see those key features kind of highlighted again. So no changes to the things that you're able to do and normal memory testing. I think this is a little bit nuanced. And so you'll see when you go to the doctor, or your loved one goes to the doctor, often people will be asked, do they prepare their own meals? Do they manage their medicines on their own? Do they do their finances on their own? And this could be nuanced because preparing a meal could be microwaving something, or it could be making a more complicated meal. And what we're looking for is somebody still kind of at the level of function that they previously were. So if you never were a good cook, if you always were somebody who just popped something in the microwave, we don't consider that a change. But if you previously were able to make complicated recipes and now are having more trouble doing that, that's something that we try to pay attention to. Things that can worsen memory at any age are stress. And so you could think about, both Dr. Callahan and I work with medical students, and we often see with our students who are under a lot of pressure, have exams coming up, maybe not sleeping well, maybe multitasking, maybe they're on TikTok instead of listening to us expound our knowledge, that they have some trouble with their memory. And so these are things that we could work on to try to improve our memory, trying to work on our stress, trying to work on not multitasking, trying to get a good night's sleep without medication. I often think about the lack of sleep with new parents, parents of newborns, how they're getting very disrupted sleep, and often they feel like their memory is disrupted as a result. And so these are things to think about for older adults as well. With medications, I want to just highlight that sometimes it's medicines that are over the counter that could be causing problems with memory, and sometimes it could be medicines that are prescribed by your physician. So that's something for us as doctors to review with our patients, and for patients to bring up with their doctors, particularly over-the-counter sleep medicines, and some of the over-the-counter allergy medicines can cause worsening memory problems in older adults that might not have caused those problems when you were younger. So that was a kind of a quick description of normal aging. Now we're going to transition to mild cognitive impairment. So mild cognitive impairment is this intermediate phase or stage between normal aging and dementia. So patients will come in to our office and they'll say things like, I feel like I'm having some trouble with my memory, or a family member of the patient might notice it. And in this case, compared to normal aging, we actually do find some abnormalities on the memory testing or cognitive testing we do in the office. But again, similar to normal aging, there's been no change in daily function. So I'm hungry, it's the lunch hour. If patients were making these complicated meals before, they're still able to do that, even though we're finding some abnormalities on the memory testing. Why differentiate then between mild cognitive impairment and normal aging? The main reason that we do differentiate is these patients who have mild cognitive impairment are at an increased risk of going on to develop dementia. It's not 100%. So if somebody has mild cognitive impairment, it doesn't mean that they definitely will go on to develop dementia, but 5 to 6% of patients do progress to dementia each year. So as physicians, we want to keep a close eye on these patients, and we ask them to come in about every 6 months to a year to check in and see if there's been any worsening in their memory and their functioning in particular. And often we're getting this information both from the patient and from somebody who knows the patient well. Okay, so now I'm going to transition to talking about dementia, because I think this is something that a lot of my patients and my own family are concerned about, because there's a lot of information about dementia in the media, and obviously it's a disease related to aging. So thinking about the brain and all of the many things that the brain controls, this is an image of a simplified image of the brain with all of the many things that the brain helps to control. Cut off at the bottom here, you can see the brainstem, which also controls for just basic things like breathing, and you're maintaining a normal temperature. But shifting to this slide here, you can see the frontal lobe, which is where you would expect it to be, right by your forehead at the front of your skull. And this controls things like your ability to move, your behavior, your personality, your ability to figure out problems, and your speech. The temporal lobe, which is kind of by your ears, by the sides of the head, this is important for language, memory, hearing, and emotion. So these are two parts of the brain that are often affected by dementia. So dementia is also sometimes termed neurocognitive disease, and there can be different types of dementia in one person. It is, some types of dementia do have some distinctive features, which Dr. Callahan will talk about shortly. What is dementia? Because this is a term that gets kind of thrown around. So this is a loss of brain function, and it can affect not just memory, although memory is the one I think that most people associate with dementia, but also judgment, thinking, and language. So sometimes patients with dementia won't be able to recognize that they themselves do have some problems with their thinking, and they may not be able to reason or make good decisions because of that. In the case of dementia, compared to, again, going back to mild cognitive impairment, there is some interference now with independence in everyday activities. So the ability to prepare a meal, which I keep going back to, it may become difficult. I think two of the activities that can become challenging in the early on are managing medicines or managing finances, because those two tasks are pretty complicated. And so that could be where there's some early signs of dementia, if there's some problems with those three tasks. These symptoms for a patient with dementia can vary from day to day and person to person. So I think that can be difficult sometimes for families to notice, because they might know what dementia looked like in their mother-in-law, but then if it's happening in another family member, it might look different because the symptoms can vary. There are abnormal results on cognitive or memory testing done in the doctor's office as well with dementia. And then, unfortunately, it is a progressive disease, and it is incurable. There are things that we can do to target to help prevent dementia and to slow the decline. So we will talk about that in this talk as well. I want to highlight that dementia is an umbrella term. So one of the things Dr. Callahan and I both see in the office is patients will, and family members will sometimes get confused when we say we think that this is dementia, and they'll say to us, but it's not Alzheimer's, right? And Alzheimer's is actually a type of dementia. So you can see here some of the most common types of dementia. Alzheimer's is the most common, and then vascular dementia, and then Lewy body dementia, and then frontotemporal. There are actually other types of dementia as well beyond what's on the slide, but these are some of the more common types that we see in the office. Okay. So I wanted to talk about domains of cognition. So these are different ways of thinking. So learning and memory, that's remembering names and items. Executive function, we'll spend a little bit of time talking about, because that's pretty important. And it's the ability to manage bills, perhaps. It's what allows you to manage medicines. And I keep coming back to these recipes. It also allows you to be able to manage emotions, for example. So maybe you're really angry at the store clerk, but you're able to kind of hold it together and not show that anger. So executive function helps in those areas as well. Attention, if there's difficulty with attention, it might be difficult for somebody to pay attention to what was going on in a conversation, and they might get distracted easily. Language, with difficulties with language, people can sometimes have trouble finding common words. And with visuospatial problems, people can sometimes fall or get lost. So sometimes actually falling can be how someone presents to care. And when we evaluate for cognitive impairment, we find that there actually is some memory issues. Okay. I did want to go back to executive function because that's kind of a medical term. And just to go into a little more detail, executive function is what allows you to plan out your day, to schedule things, to organize your month ahead, to organize your apartment. And it's what allows you to focus or shift your attention, maybe to strategize and see what is more important for you to do right now, to be able to, the executive function allows you to remember instructions. It's part of your working memory, as we call it. And as I described before, it also is what allows us to manage our emotions. Um, Dementia is a tricky disease because it not only can it affect your memory, but it also can affect people's personalities. And Dr. Callahan and I have both seen people soften with the dementia. And we've seen people kind of become more agitated or angrier with dementia. It can affect mood, and sometimes there's some depression or anxiety on top of the dementia. It can affect motivation. So a lot of what we sometimes see is apathy. So an activity that somebody used to really enjoy, they're no longer as interested in. And I think that's hard for families to see that kind of loss of interest. And it's important to remember that this is part of the disease, not the person. There can also be changes in sleep patterns. Often people might be awake at night and asleep during the day. And again, this can be very challenging for families. So that can be a real challenge. With the changes in personality, there could also be some impulsiveness or a lack of empathy. And again, I think those feel like things that are the person, but it really is the disease, and it's difficult but important to try to remember. Um, as dementia progresses, it can become difficult for people to do even simple things like brushing their teeth or choosing the right clothes given the weather outside. So they will need help doing those things. People might forget details about current events, and they may forget events even in their own life history. At later stages, pretty fairly advanced stages, people can develop problems with swallowing and even problems with walking or sitting up. So we see those motor aspects, the how the motor, the brain works to help control with walking be affected. And then there can also be hallucinations and delusions. So people believing that things are being stolen from them or seeing things that other people don't see. This can happen at any stage, but tends to happen later in the disease. So I'm going to hand it over to Dr. Callahan for the rest of the talk.
Okay, thank you, Dr. Bhatia. So good morning, everybody. I'm going to take it over from here, and I'm just going to show you again this umbrella picture. I like to describe this to my patients as dementia is the umbrella term, with a lot of different types of dementia that we see. And of note that there can be several of these problems occurring in one person together. Very often we see somebody with some features of Alzheimer's disease and vascular dementia together, and that could be seen clinically and when we look at people's brains MRIs. So I'll spend a few minutes talking about each type of dementia. As Dr. Bhatia said, Alzheimer's disease, it is the most common type of dementia we do see. It is more common after the age of 65, but I'm sure you've seen this horrible disease occur in people younger than 65. We've seen that, and that is just called early onset Alzheimer's disease. Of note, though, the incidence does double about every 5 years. After every 5 years, there's a lot of different statistics thrown around that says that over the age of 80, up to 50% of the population can have some degree of Alzheimer's disease. So it does keep going up with age. I made note of this term amyloid deposits. This is the pathology that is seen both on autopsies and also some of the imaging, which I will be talking about in a few minutes. The amyloid deposits are these toxic proteins that build up in one's brain. It is the major target now for a lot of these new medications, which I will be mentioning, and you may have seen this in the news and newspapers and media and magazines, everywhere it is. Of note, though, these amyloid deposits can be seen up to 15 years before the person has any symptoms and presents to medical care. So this is why there's been a lot of push to look at these amyloid deposits early on and not wait for symptoms to appear. So that's Alzheimer's disease, the most common form of dementia. The second most common form of dementia is vascular dementia. This is due to damage in blood vessels in the brain. And I describe it as somebody that's had strokes, mini strokes, or silent strokes. What does all this mean? Strokes are, everybody knows for the most part what a stroke presents like. It has some facial drooping, person can't speak, they can't move their hand or the leg. Those are the strokes that a lot of people are aware of. Then there's this term called mini strokes where they may have some symptoms like that, but then it resolves within about 24 hours. We term that TIA, but in reality, those are mini strokes. Those are damage to the brain. And then there's a term called silent strokes where the person may not have symptoms, but if you do an MRI or a CAT scan, you might see evidence of somebody having a stroke before that. So we would call that a silent stroke. How do you see this? It might present as a stepwise decline in cognition. There might just be something where the husband or wife can say, "Oh, I remember she did act a little differently and she was never the same since that." So we think about it as a stepwise decline in cognition. The risk factors are what you would think about for heart disease too. High blood pressure, cholesterol, diabetes, smoking. These are the risk factors that we really want to treat to help prevent vascular dementia from occurring and or getting worse. So the third type of dementia where you may be hearing more and more about this, we are diagnosing it earlier on. It is something called Lewy body dementia, LBD. It's really the third most common type of dementia, and we're seeing it in some of those patients that have some Parkinson's types of features, Parkinson's disease, where they may have a little bit of a classic tremor. They have some gait disorders. There may be a little slowing down. So there's more of a physical change also. Some of the other really classic defining features are sleep disorders. It's what we would term a REM, the rapid eye movement sleep disorder, where the partner may say, "Oh my gosh, my husband has been thrashing at night, throwing the blankets off, wild dreams, winding up on the floor." Those are sleep disorders that are seen very commonly in Lewy body dementia. Another feature of Lewy body dementia are something called visual hallucinations, and these can occur very early in the disease. It can be, the person saying they're seeing little children or animals in the apartments. That's not always the way, they might see them, but in visual hallucinations, and they can occur very early in the disease, as opposed to the other types of dementia like Alzheimer's disease, where the hallucinations and delusions might be later on. So these are very important clinical features in Lewy body dementia. Frontotemporal dementia is another type of dementia. We don't see it as much in geriatrics. Usually our neurology colleagues see this because they usually present earlier. I put the picture up of Bruce Willis. Sadly enough, he is diagnosed with frontotemporal dementia. This can be a really hard thing to diagnose early on because the patient again, it affects the frontal lobe, right? Personality changes, problems with language. If you remember a few years ago, he was diagnosed with aphasia. He was having trouble with his language before they released that he had frontotemporal dementia. So usually it's a language problem, personality change. They may have difficulty with planning. So this may be, as Dr. Bhatia was talking about with the executive function, this may be somebody who's just kind of mixing things up at work. They're just not doing the things that they could normally handle. They may not necessarily have memory problems early on. This may become with it or later on. Again, these are the younger people that usually our neurology consults, our neurology colleagues see. Very difficult to diagnose early on, but something to think about in some of those younger patients. And like I said, Bruce Willis is diagnosed with this. Okay, so that's a brief overview of the different types of dementia. So if you think your loved one has dementia, or even yourself or a friend, a colleague, what do you do about that? It's really a scary prospect. First, I encourage you to talk to that person about that. Talk to your loved one about your concerns. I will bet they will not welcome that with open arms. So be gentle, be understanding. A lot of people do not want to face this. It is a really scary prospect. We would encourage that person to see their PCP first, the person who knows them the best. And I'm going to go over about what an evaluation is, but the first thing should be to see their primary care doctor. The third bullet we have down here is to try to schedule an appointment with a geriatrician, a neurologist, or a psychiatrist, because I'm doing this now, and I think we need to understand that any of these types of physicians can do an evaluation. There's a shortage of geriatricians, a shortage of cognitive neurologists, and a shortage of psychiatrists. So I would encourage you to start with your PCP and then get appointments for a good evaluation with one of these specialists. Because the evaluation is very, very, very extensive, and this takes a very long time. The bulk of the evaluation is really doing a very extensive history. We want to hear from you. We want to hear from your family. We want to hear from a loved one. Ideally, when I say a family, it could be an aunt that lives nearby. Ideally, it would be somebody who sees you or that person on a regular basis, not a daughter who lives in California who really doesn't have much contact with the person. We really would like a reliable informant, somebody who knows the person in the office with them. Because imagine if there is some memory problems, we need somebody to be there to say, no, that's not exactly how it happened, or this is my concerns. We do recognize that people have to work. So I do tell my patients' families, just you can call in, you can FaceTime in. You don't have to always be there if you're not able to be there. That is the bulk of the evaluation. Then we do cognitive testing, and I'll show you a picture of one of the common tests that we do. Some patients are referred to a neuropsychologist. A neuropsychologist is an actual PhD trained psychologist who will perform neuropsychology testing in their office. This can take about 3 hours. Medicare does cover it, but it is an extensive visit. It's kind of just picking apart different parts of the brain and how they're functioning. Not everybody needs a neuropsychology evaluation. Not everybody should get one, and that's really up to the discretion of the person doing the evaluation. It is important to evaluate somebody's mood. All right, we do see this a lot. Depression and anxiety can predate the dementia. It can be kind of a precursor to a cognitive impairment, or it can occur with cognitive impairment. So we do encourage people to get their mood evaluated and treat if appropriate. A big important piece of what we do as geriatricians is a medication review. And that is both prescription and over-the-counter. As Dr. Bhatia said, there's a lot of cold and sleep medications that can affect your memory, and other medications too that we do prescribe for our patients. The physical exam is always an important part of the evaluation. We really want to look at, what the person looks like, how they're coming into the office. Are they dressed okay? Are they showering okay? These are things that we always look at in addition to a neurologic exam. We do perform some blood work. There's not really supportive data behind some of these things, but it is important we make sure the B12 level is adequate. We check their thyroid level. Those are quick and easy blood tests. I italicized here this blood amyloid biomarker because I'm sure there's a lot of questions about this, and I will try to touch a little bit on this, but the blood amyloid biomarkers are now FDA approved as of a few weeks ago. You can get them done at certain labs. Not every lab does it. We do it here at Mount Sinai as part of a research project, but it's put in the context of the evaluation. It is not just the evaluation. Brain imaging is also important. And what type of imaging that may be, it really depends on the person and the person doing the evaluation. Some people get a CAT scan, some people get a brain MRI, some people get an amyloid PET scan. That's a very fancy scan. But again, putting in the context of what the patient is complaining of and their story and what the physician is seeing. Okay, this is just a picture of the MoCA. Don't try to memorize it because they do come out with other versions, just so you know. And as Dr. Bhatti and I were saying, diagnosing dementia is not just a memory problem. And this is an important thing to remember here. This MoCA encompasses things like addresses or evaluates visual spatial problems, executive functioning, attention, language, abstract thinking, delayed recall, and then orientation. All right, so this is pretty complex evaluation. It takes about 10 to 15 minutes to do. The perfect score is 30. We like to see a 26 and above, but it can depend on other things like education too. So this, don't be surprised if you see this more and more in the doctor's office. All right. So we talked about the types of dementia, how the doctors evaluate it. Now, what do you do with this? There are medications that are out there on the market. These have been on the market for about 25 years. In the dementia world, it's been very frustrating for a lot of physicians and definitely patients that there's really not a lot more to offer patients. All the studies just show failure basically of other newer drugs that are actually helping. But these have been around, these medications called cholinesterase inhibitors. They affect certain brain chemicals called acetylcholine in the brain. They do not target the amyloid deposits, and that's an important thing to understand. The three that are on the market for over 20 years are donepezil, the brand name is Aricept, galantamine, the brand name is Razidine, and then rivastigmine, the brand name is Exelon. There's really no good head-to-head studies to say one is better than another. One is once a day, one is twice a day, one comes in a patch. So they all pretty much interchangeable. They can be given at any stage of dementia. And what I mean by that is early, moderate, or late. Okay, so we do prescribe them at any stage. I did make note here, Lewy body dementia, that LBD, it has been shown to help prevent or help decrease the hallucinations that patients with Lewy body dementia get. And there is some studies to support that it can help some behavioral problems with patients that have Alzheimer's and vascular dementia. So we do prescribe it for other reasons too, in addition to some of the memory and cognitive complaints. Some of the side effects are some nausea, diarrhea. Some people get some EKG changes. It's not as common. Some people have some increase in urinary frequency. And the reason that is because it affects this chemical that can affect your bladder also. And some people complain of insomnia. Another feature can be bad dreams. I had a patient years ago that said, I'd rather get a good night's sleep than take this medication. But again, most people do tolerate this medication pretty well. There's really no blood test to check for it. And if you do have any of these side effects, we just stop the medication. This class of medication does, we do say that it may help slow the progression of disease symptoms. It is not a disease modifying drug. There's really nothing for us as the physicians to measure any improvement or lack of improvement, but it's something the families make note of. You know, I've heard, well, my mom talks a little bit more, her language is a little bit better, she's remembering a little bit more, which is definitely a good thing, but it's not something that we can measure. So that's the cholinesterase inhibitors. The other class of oral medications that has been around for over 10 years, 15 years is memantine. The brand name is Namenda. It is FDA approved for moderate to severe dementia, also pretty well tolerated. The biggest side effect is dizziness. And it's been marketed to say that it may help with some cognition and quality of life. Again, it works on a different chemical in the brain, not amyloid. I would be remiss without mentioning what we also encourage as treatments for dementia. You have to really treat vascular risk factors. We can't just think about the medications for Alzheimer's disease. We have to think about the brain, vascular risk factors. I'm not telling everybody to go out and start an aspirin. I'm not telling everybody they need a cholesterol medication or more blood pressure medications, but these are the big vascular risk factors that should be managed, treated, in addition to the other medications that I mentioned. If somebody is really suffering from mood problems, depression, anxiety, really you should talk to your physician, because these are so important to treat, and it may help your memory if we treat the mood or anxiety problems. I put down here sleep hygiene because a lot of patients know they should get a good night's sleep, want a good night's sleep, but they should not be using sleeping pills. This is a whole talk in and of itself in terms of how to help somebody get a good night's sleep. But sleep hygiene is a term that's thrown around a lot in our practice. So it is important to practice good sleep hygiene and avoid sleeping pills. Okay. So this is a new class of medications. I'm sure a lot of you have heard about this. About 3 years ago, it was all over the New York Times, these IV infusions. The first one that was marketed about 3 years ago, it was all over the New York Times, all over the media, the aducanumab, that is now off the market. These are anti-amyloid beta monoclonal antibodies. They're given by IV infusion. This is the first new line of medications in over 25 years. So it's really important to recognize that some progress is being made. The two that are on the market now are the lecanemab, which is Leqembi, that's the brand name, or donanemab, which is Kisunla, that's the brand name. What about these anti-amyloid beta monoclonal antibodies? As geriatricians, we don't necessarily love these per se. So what are they used for? They're used with people that are diagnosed with mild cognitive impairment or early Alzheimer's disease. And there's different institutions have different ways to define early Alzheimer's disease. Some of it is the score on the MoCA. Most of it can be a score on a different office test. It's a very individualized criteria that each institution has. But there should be evidence of amyloid plaque on the brain, and that could either be on a PET scan or in a lumbar puncture in the cerebral spinal fluid. That's a lumbar puncture is done. It is got a huge, very long list of contraindications, which I didn't even put up here because that's a whole nother thing. But a lot of patients really are not eligible for this medication. What are the benefits? And this was a very controversial a few years ago when these were first FDA approved. There was a lot of backlash to the FDA when they approved this. Sure, it does show that there's a good reduction of amyloid plaques on the brain imaging. But the problem is clinically, meaning what the doctor can see, what the patient sees, what the family sees, it really was a very minor improvement. It does not improve cognitive function. It may slow the progression of the disease by about 25 to 30%. One of the things they say, it may slow it down by about 3 months, but it still is going to progress. So the problem was, there's some benefits seen on the imaging, but not necessarily clinically in real life. What are the side effects? This is the big problem. There's a lot of side effects here. Sure, you can have some infusion-related reactions just from the IV, but this thing called ARIA, which is amyloid-related imaging abnormalities. You may see that in some of the articles you might read. Your brain could have some bleeding, microhemorrhaging, or swelling, edema. So it's ARIA H and ARIA E. Some of it may be asymptomatic. So the patient may have these imaging or these brain problems and they don't even know they have it. That is why the person needs to get serial brain MRIs, and there's protocols on it when you have to get it and so forth, follow-up brain MRIs. The risk of these ARIA side effects vary anywhere from 28 up to 40%. It depends on your genetic testing. You need to get genetic testing, not to get the medication, but to show your risk of developing some of these ARIA side effects. So again, a lot of side effects with these medications. There are a ton of challenges also. These are very expensive. When the aducanumab was approved back in 2022, they were saying, the drug companies were saying it was going to cost about $100,000 per year for these medications. They've dropped that to about $50,000. Since that, it's dropped even more, but it's still very, very expensive. Medicare does cover it now. It is given via an IV infusion. It's every 2 to 4 weeks. All right, the one is every 2 weeks, one can be every 4 weeks, and you do need serial brain MRIs. So this is a big commitment. It has to be done at certain centers. Sinai does it, Cornell, Columbia, they do it. But it really is done in a specialized center because it can be somewhat dangerous. Okay. Separate from all of that, what do we tell all of our patients? These are things that everybody can use at every age. Maintain a routine. All right, keep things, if somebody does have even normal aging, mild cognitive impairment, or dementia, routine is crucial. I've seen so many times where somebody takes their mom or dad to the, grandson's graduation across the country, and that just wreaks havoc with their memory and thinking and mood and behavior. So keep routines. Get enough sleep, again, without sleeping pills. Keep active mentally and physically. I always tell my patients, now is not the time to become a couch potato. Get off the couch, and do something to stimulate your brain and your body. Organization is crucial, again, at any stage, right? At any stage of life, but definitely as you get older, keep lists of things, write things down, keep a calendar, keep a book. If you're constantly going to doctor's office, keep things written down in a place where you know where things are going to be. I always say, as I'm saying, keep your brain active, but delegate unwanted tasks. If something is stressing you, like if you dread tax season, you can do it, it just causes you a lot of stress, get rid of it. And then also treat anxiety and depression if you have those symptoms. Don't ignore those. I love this slide because I think it really drives home the point that some of this can be in our control. This was a study published in the Lancet, and they call it the Lancet Commission. It was a huge article looking at dementia prevention, intervention, and care last year. And there's a lot of different things that increase your risk of developing dementia along the lifespan. Less education. We know that people with higher education are have a decreased risk. And then a lot of things happening in midlife and also late life. Things that we do know as doctors, if you have hearing loss, that may increase your risk of developing dementia. Things that we mentioned before, cholesterol, depression, traumatic brain injury is important too, physical inactivity, and then these other risk factors. Excessive alcohol is also important to avoid in midlife. Late life, try to remain socially active. Can't really do much about air pollution these days, but also visual loss. These are important risk factors that they do say that if a person can tackle all of these along their lifespan, they may drop their risk of developing dementia by about 45%. All right, so these are really important lifestyle changes that you can institute at any point in time. And in the world of geriatric medicine, we are seeing a lot more studies supporting treating blood pressure. And I hope your doctors do this with you. Years ago, we always accepted, okay, a person's getting older, their arteries are hardening, so we can accept a blood pressure of about 150 over 90. And when I started training, that's what was okay, because we felt we needed to get the blood up to the brain. If we drop the blood pressure too much, that would be more detrimental. But over the past couple of decades, more importantly, the past few years, we do know that treating high blood pressure in midlife and even later life is a strong, high blood pressure is a strong predictor of dementia. It's never too late to control blood pressure, but I implore you to talk to your doctor to see what's best for you. We do like to aim for about 120 over 80, but again, it's a risk benefit discussion with your doctor. We don't want you to drop it too low, because then that opens up a whole nother can of worms. We do encourage our patients to check their blood pressure at home, because it's often more reliable than the stress when you're sitting waiting for your doctor in the waiting room. So check it at home. Bring in your log to your doctor. Several medications may be needed to help manage blood pressure. Again, this is a whole nother topic, high blood pressure in older adults. We do tend to use a few different medications. We'll both have patients that are on 3 or sometimes 4 medications. The idea is you're using low doses of several medications, so you get some benefits while decreasing some of the side effects of that particular medication. And it's important to follow with your doctor often. If you have a problem like high blood pressure, the doctor's going to be going over some blood work. They'll be reviewing your diet with you and talking about all the different medication options. So it is really important to manage blood pressure to help protect your brain. Other ways to keep your brain healthy, and these are some repetitive, but I think it's important to drive this home. Get a good night's sleep. Get off the couch, exercise. We didn't touch on the Mediterranean diet, but that is an important thing for a lot of other reasons. A lot of heart benefits, but also brain benefits. Limit alcohol use, and there's been a lot of data, a lot of reports in the media now about, is any alcohol safe? Um, that's a topic to be discussed with your doctor. Stimulate your brain. I tell patients, maybe learn a computer skill, maybe try dancing. I have some patients that are actually going to start learning another language. So try to stimulate parts of your brain that, you're not really using. Socialize, socialize, socialize. Get out there and meet people and learn a new skill, as I was mentioning, right? Learn how to use a computer. Go to the Apple store and sit down with one of the geniuses at the Genius Bar. Or learn a new language, go to lectures, things like that. I'm going to end it with this slide. All right. I feel like this every day. There's too many things to have to remember. All right. So here are some resources. There's a ton of resources out there. If you just Google brain health, memory, dementia, you get bombarded. These are some of the things that I found helpful. NIA, hopefully that's still helpful. Alzheimer's organization, the Mayo Clinic has some nice lifestyle tips, and an organization we refer a lot of our patients to is Caring Kind NYC. Those are for people who do have a dementia, but there's also some healthy brain tips in there also. All right. And thank you for listening. And we are here for questions. My part, she's not ready. Oh, yes, my partner. So I'll read it out loud. My partner keeps saying she is, quote, not ready for evaluation. She obviously has lots of these symptoms. That is the more common scenario. We see this most of the time. Nobody enters this world willingly, in terms of the world of cognitive impairment evaluation. Be very supportive. I would recommend to go onto some of those websites, how you can help your partner early on and let her be ready. I think it is also important, to gently, if you're allowed to visit the doctor with her and suggest some of your observations, if she's okay with it. The problem is we see this and the doctors are in and out of the visits in 10, 15 minutes. So unless somebody is coming to their attention, saying some of these issues, they don't get evaluated. And there's never been a recommendation to do mass screening. That's never been a recommendation. But so we won't know about it until we see something, if they're coming in late for appointments, if they're mixing up their medications, if they look a little bit, not dressed appropriately. There's not much that we're going to see, but it is important to hear from you as the partner.
If I could add to that a little bit, one other thought I have is maybe saying, I hear that you're not ready. And one way we could kind of work around this is deciding how much we tell you. Like, so if maybe we could do the evaluation and any information could be filtered to the partner rather than to the person who's experiencing it. Because I could also understand that I have a patient who's coming to mind as we're having this discussion who said, I don't want to have an evaluation because I think being labeled with this diagnosis will depress me. So we've kind of worked our way around it the best way we can. And I share my findings with her daughter. She's given me permission to do that. So that might be one way to kind of work around it and say, like, would you be comfortable if I went and spoke with the doctor and if I got information about what's going on and then could filter that to you in a way that feels more comfortable for you. So just some thoughts.
And then are there any postmortem brain studies, brain donation? Yeah, that's where they get a lot of their pathology data from, or the brain banks. And, the problem is a lot of people are declining autopsies now these days as opposed to years ago. So yeah, there are brain banks that I would, if there's any interest, reaching out to, I guess, your doctor to start. And then Alzheimer's organization, there's the Alzheimer's Disease Research Center, that's the ADRC, that is part of Mount Sinai and other big institutions, and they can point you in the direction. But yeah, that's where they get a lot of their data from, is the brain autopsies. Oh, that's a great question, Carlton. Should I be concerned about the disease being passed down genetically? That we didn't even touch on the genetic aspect of this. It is, as I mentioned, the disease is much more common as you age. But if you have a relative that's 80 years old and diagnosed, it doesn't necessarily mean it's a genetic problem. There are genetic tests that are done also looking at the ApoE gene. The problem is you could have the gene and not have the disease. This is still why we're in such a dilemma with screening and kind of coming up with risk stratification. So usually what we think, if it's more it may be more genetically related if they're younger, if they're under the age of 65 and you have multiple family members, right? We do know some of those patients that have several family members diagnosed in their 60s. 70s, 80s, it's something to think about, but again, you can't change your family tree, so that would be even more important than to target those risk factors that I was trying to talk about a little. I know it's not the best answer. Leqembi was FDA approved yesterday for home administration. So we're just in the middle. Was that yesterday? There's discussion about this. They are approving a sub-Q administration. I've never seen it saying they can give it at home. I can't even imagine that happening right now. The sub-Q administration has been discussed. I wasn't aware of that actually happening yesterday. We were just talking yesterday, Dr. Bhatia and I, about the home test available now for the different blood biomarkers. I would recommend caution with these because, again, we don't know what to do with these. These blood biomarkers are recommended to be done in the setting of a full evaluation, and really on people that have some impairment. And that could just be anybody, right? There's not strict criteria, but it's not necessarily used as a screening tool. And that's an important thing. These are new tests. So I would really be careful with the idea of testing at home. And I've never heard of doing the sub-Q at home. I would be very, very cautious on that. But this is one of the things that I was just in a meeting with a neurologist about on Tuesday. This is coming. Sub-Q injections are coming. A lot more patients are going to want these medications. We have not changed our protocol on any of the recommendations on follow-up with the MRIs. I think in the next few years, we're going to see a lot of changes, but right now there's a lot of side effects with these drugs. The patients have to be picked carefully.
If I could add just one, I see there, sorry. Although the suggestions I'm sorry, there was one more comment that crept in. I've been practicing internist and geriatrician for almost 25 years. Although the suggestions of prevention are encouraging and I am familiar with all of them, they do not always work. Case in point, my own mother developed Alzheimer's about 12 years ago, despite doing everything on the list to take care of her. I'm sorry to hear that. And thank you for sharing. Yeah, no, I'm sorry to hear that. And there is, I guess I was about to talk about prevention, so I appreciate your comment and your question. I think obviously these diseases are very difficult to manage. I think one silver lining, I guess I would say, is that education, as Dr. Callahan mentioned, and the vascular risk factors are really important to help prevent dementia. And one of the things that we're seeing is that even though the numbers, so the absolute numbers of people developing dementia are expected to increase because the population is increasing, the percentages are actually expected to go down because people do have more access to education than previously. And also we're doing a better job with vascular risk factors. Yeah. I feel like those are two kind of positive things to kind of leave what this talk with, I hope.
And I think that's an important thing too. There's still so much that's not known. As Dr. Bhatia said, managing these risk factors all along the lifespan is so important. And in terms of the data, one of the things that you think about with the data with these infusions, sure, if it gets rid of a lot of the amyloid plaque, how come you're not seeing such a dramatic improvement in the memory and cognition? So we know that there's something else going on. We know that there's something besides the amyloid plaque. We just don't know what that is yet.
We do have a couple minutes left. I have a couple quick questions for you. You mentioned early on about certain medications, either prescribed or over the counter, that can affect memory. Mm-hmm. Is that reversible if you stop using a medication?
That's a great question. Theoretically, yes, but there are some longitudinal data to suggest that long-term use of what we call the anticholinergic drugs. All right, those are some of the old-fashioned tricyclic antidepressants from years ago. Over-the-counter ones, the ones we think about are the diphenhydramine, the Benadryl. I would implore everybody with cold and flu and allergy season coming up to look at the labels on their boxes of medications and bottles of medications. Avoid anything with diphenhydramine in it, because acutely that can make you more confused. Long term, maybe, we're just not sure.
Okay. And a final question, are there any treatments for vascular dementia? Like I know they use stents, right, for blocked arteries. Is there anything like that?
No. Well, the problem is those are for the large arteries. That's what we're finding is more of the small arteries embedded in through the brain. So it's not for prevention. It's really the large arteries that you're referring to with the stents. The After the fact, after we see strokes, they're usually more the smaller arteries that you really can't tackle. Now, if somebody is having a stroke, there's the the clot busters that are given, but that's in a hospital setting. So it's really a lot of these risk factors like high blood pressure, diabetes, cholesterol, smoking. Those are the big things.
Right. Well, we are out of time. Well, thank you so much, doctors. Really
Welcome.
appreciate it. And there were a number of nice comments in the chat. Thank you.
Thank you, everybody. Take care.